Can I start, sir?
Saurav, can we start?
Yes, sir. You're live now.
We can start, isn't it?
Okay, sir. Okay, sir. Thank you, sir. Hello, everyone. Today's my topic is empirical antifungal treatment, and my moderator is Dr. Srinivas Samvedam, sir. Invasive Candida infection. It is a fourth most common nosocomial blood infection in the USA. As per studies, most common is cons, followed by Staph aureus, followed by Enterococcus, and fourth one is Candida species. And incidence is 7.6%. Candida is Candida albicans and Candida non-albicans species. Candida albicans is most common, which is 60%, and non-albicans species is 40%. In India, Candida tropicalis is the most commonly isolated non-Candida species, followed by Candida glabrata and paraphylosis. Candida tropicalis is particularly prevalent in the tropical regions like India and is associated with more persistent infections and high mortality rate compared to Candida albicans. Candida auris is emerging and multi-drug resistant fungal infection that has gained significance as a global healthcare concern, particularly in the Indian healthcare setting, and mostly it is most common in the North India in Delhi. Candida krusei, Kiefer, Candida lucinae also identified in the India, but their rates are very low compared to other non-Candida albican species. Most common Candida non-Candida albicans are Candida tropicalis. It is considered by the second most virulent Candida species, followed by albicans. Most common in the patient with neutropenia and malignancy. Virulence factor of the Candida tropicalis include adhesion to the buccal mucosa and endothelial cell, secretions of lytic enzyme like proteinase, phospholipase, and hemolysins, and phenotypic switching. It is a strong biofilm producer. It shows resistance to azole and very high resistance to fluconazole specifically. Currently, echinocandins show the excellent activity against tropicalis and a good option for the treatment. Candida glabrata is especially found in elderly patients. Long incubation period, result usually available in after 6 to 7 days. High mortality compared to Candida albicans. Worst prognosis among all Candida infection and increased resistance to fluconazole. So that treatment is with echinocandins. Candida paraphylosis is especially found in the children's, frequent in the neonates and adolescents, and particularly in the healthcare setting where it can cause the bloodstream infection and other complications. Best prognosis among all Candida and azole is drug of choice. Candida auris is emerging Candida and first reported in the Japan in 2019 in the ear canal infection. So it is named as Candida auris. Candidemia due to this yeast has been reported in India and incidence are 5.3% cases in the ICU. It is a global health concern with potential outbreaks and very high mortality rate. It is spread through the direct contact with the patient's contaminated surface and environmental contact. It is a multi-drug resistant, especially to the azoles, particularly fluconazole, as well as other antifungal like polyenes and echinocandin also it show resistance. Symptoms are the fever, lethargy, in few cases, ear infections. Aspergillus. After Candida, Aspergillus is the most common fungus. Its occurrence is classically in the immunosuppression patient, transmission by the aerogenic inhalation of spores. No human to human transmission reported. Sources are the air condition with inadequate filtration. Spotting soil, therefore, no spotted plant should be placed in the patient's room or the wards in the hospital due to spread of the aspergillus. Renovation work, demolition work like construction site, and whirling of the rotten leaves. And types of aspergillus is Aspergillus fumigatus, Aspergillus flavus, Aspergillus niger, Aspergillus nidulans, Aspergillus terrens, Aspergillus parasiticus, and Aspergillus repens. In this, Aspergillus fumigatus is the most common type. Diseases caused by aspergillus is allergic bronchopulmonary aspergillosis, ABPA, aspergilloma, detection in the preformed cavities, invasive aspergillus tracheobronchitis, invasive pulmonary aspergillosis, IPA almost always involvement of the lung and possibly also paranasal sinuses. Mortality is 70%. Disseminated invasive aspergillosis is especially in the brain and mortality is 100%. Epidemiology, Candida is the fourth most common in the bloodstream infection. 17.8% of all species cases as per German prevalent study. In the MaxSep study, which include patients with a severe sepsis or septic shock, 2.3% of all patients show the candidemia. Mortality due to candidemia is 50% and due to aspergillosis is 70%. Increased cases of the invasive mycosis is due to increased number of the immunocompromised patients in the ICU and increased life expectancy of the morbid patients in the ICU. And invasive mycosis in the ICU is exclusively nosocomial infection, and severe infections are typically which do not responded to broad spectrum antibiotics are mostly due to fungal infections. International study of prevalence and outcome of infection intensive care unit EPIC 2 study is for mainly for fungal infection, in which 14,414 adult patients are included. It is conducted in 1265 ICUs in 76 countries, in which 70% of the infected patients have the positive microbial isolate, in which 47% are due to gram-positive infection, 62% are due to gram-negative, and 19% are due to fungal infection. Mortality of the candidemia is higher than those of the other bloodstream infection caused by gram-positive and gram-negative. Prevalence of candida infection is 6.9% per 1,000. UCandid ICU study. It is an incidence and outcome of invasive candidiasis in ICU in the Europe. It is a multicentric study conducted in 9 countries in 23 ICU units, retrospective observational studies, and it is a frequency and outcome of invasive candidiasis in the Europe, in which result is invasive candidiasis incidence is 7.07 episodes per 1,000 ICU admission, in which candidemia is 5.52, intra-abdominal candidiasis 1.87. Mortality after 30 days due to candida infection is 42%. It is mainly because of candida albicans 57%, glabrata 27%, and paraphillosis is 13%. Risk factor for candida are the protracted antibiotic therapies, especially broad spectrum antibiotics like ciprofloxacin, and increased incidence of candidemia. TPN, total parenteral nutrition, malnutrition, long-term ICU stay of the patient, abdominal surgeries, necrotizing pancreatitis. In abdominal surgeries, especially hollow organ perforation like small intestine surgeries, in which 35% abdominal candidiasis is seen. In upper GI surgeries, almost 41% patient have abdominal candidiasis. Therefore, in anastomotic leak, in which surgeries anastomotic leak is there, we should always start antifungal therapy. Necrotizing pancreatitis, then secondary sclerosing cholangitis, diabetes mellitus, central venous catheter, renal replacement therapies, ECMOs, mechanical ventilation. Severity of the disease, Apache 2 score. Immunosuppression like the HIV, AIDS, organ transplantation, graft versus host disease, acute and chronic both. After allogenic hematopoietic stem cell transplantation, neutropenic patient, systemic steroid therapy, liver cirrhosis, end-stage disease, colonization, barrier disorder like intestinal ischemia, ileus, COPD, chronic COPD patients, premature infant in which birth weight is less than 1 kg, and hemato-oncological diseases like acute leukemia and tumors are the risk factor for candidiasis. Candida clinical prediction scores, in which Candida colonization index, Candida score, and Ostrowski-Zinsser clinical prediction rules are common. In Candida colonization index is ratio of the number of non-blood site colonized with Candida species divided by total number of sites cultured. If Candida colonization index is more than 0.5, it is suspected for the invasive candidiasis. Positive predictive value is 66%. Negative predictive value is 100%. Candida score include the TPN 1 point, surgery 1 point, severe sepsis 2 points, multifocal Candida colonization is 1 point. Threshold for Candida score is more than 2.5, and more than 2.5 is suspected for invasive candidiasis. Sensitivity of Candida score is 81%, specificity is 74%. Positive predictive value is 16% and negative predictive value is 98%. So Candida colonization index and Candida score is high negative predictive value, showing high negative predictive value. Otrensky Zenser clinical prediction role include if patient is on mechanical ventilation for 48 hours, on systemic antibiotics, CVP lines on in any 1 to 3 day of ICU admission plus any one of the following, like any major surgeries, pancreatitis, use of steroids or immunosuppressive, use of TPN and dialysis. Specificity is 50%, specificity sensitivity 50%, specificity 83%. Positive predictive value is only 10%, but negative predictive value is 97%. So all these clinical prediction scores show good negative predictive value. Risk factor for aspergillus. First is immunosuppressions like organ transplantation are at the high risk, in which or hemato-oncological patients, allogenic stem cell transplantation, especially acute myeloid leukemia in patient after lung transplantation and transplant rejection patient. Neutropenia, systemic steroid therapy, calcineurin inhibitor, HIV patient, cytomegalovirus infection patient included in immunosuppression patient. Then diabetes, liver cirrhosis, COPD, especially patients on inhaled corticosteroids are risk factor. Long-term ICU stay more than 21 days. Renal replacement therapy, post-splenectomy, malnutrition, burns patient, and viral pneumonia, especially influenza and COVID-19. COVID is increased incidence of invasive aspergillosis. It is also known as a CAPA, coronavirus associated pulmonary aspergillosis. Classical risk factor for aspergillosis is organ or stem cell transplantation, hemato-oncological disease, neutropenia, and immunosuppressant including steroids. New risk factor for aspergillosis, mnemonic is 4C, which is COPD, corticosteroid, cirrhosis, and COVID. Diagnosis for candidiasis, tracheal and bronchial secretion. Mostly tracheal and bronchial secretion is colonization only in candida infection. Laboratory diagnosis, serum PCT level, procalcitonin more than 5.5 picogram per ml. Rule out the candida infection because candida inhibit the synthesis of procalcitonin. So high procalcitonin rule out the candida infection. Blood culture is diagnostic of the choice. Sensitivity is only 30%. Possibly even special fungal culture bottles like Bactec, and in which results after 3 days, we can get results in 3 days instead of 7 days. Fundoscopy, in which mycotic chorioretinitis, endophthalmitis we can see. Serology is recommended by surviving sepsis guideline since 2012. It show high negative predictive value. Beta D glucose levels are highly specific for candida, but also it is positive for pneumocystis jirovecii infection. So beta D glucose is test is very high negative predictive value only for us. Cutoff for beta D glucose is 80 picogram per ml. Antimenin antibodies, it is less specific for candida because it is also positive in fusarium and aspergillus also. Serum PCR is not widely established in candida infection. Histopathology is gold standard for candida infection. Detection of biopsy shows invasive growth and thus proven the infection. And hyphae can be detected by PAS or Grocott staining. In case of suspected intra-abdominal invasive candidiasis, in particular, not only peritoneal lavage, but also biopsy for the histopathology is performed because it is gold standard. Candicept study, it is a beta D glucose guided antifungal therapy in the adult with sepsis. It is a multicentric study conducted in 19 ICUs, and 342 patients are included in these studies with severe sepsis or septic shock and increased risk of invasive candida infection. Results are the primary endpoint is the mortality after 28 days is no difference, and secondary endpoint antifungal free survival after 28 days, duration of organ support, SOFA score, ICU and hospital length of stay. There is a no difference in two groups, in which in this study 2 groups are there. In first group, patient with the severe sepsis and septic shock, and they started antifungal therapy as per beta D glucose, and second group is included in which beta D glucose level more than 80, but they didn't start antifungal therapy. Fungiose study, here the value of beta-D-glucan in intra-abdominal candidiasis in which blood cultures are mostly negative are examined. Beta-D-glucan value more than 80 picogram per ml show the specificity of the 78% and sensitivity of 65% for the intra-abdominal candidiasis. Tracheal or bronchial secretion study, ICU stay more than 7 days, suggestive of 60% colonization in the trachea and the bowel sample, and almost always only colonization in the tracheal or the bowel sample. There is a no primary candida pneumonia, and most secondary candida is not a respiratory pathogen. CanTreat study also shows that no benefit of antifungal therapy in the suspected patient with VAP in which candida is present in the tracheal secretion. So significance of isolation of candida species from airway sample in critically ill patient. One study is conducted in which it is a autopsy study. 232 intensive care patients are included, in which 135 patients have pneumonia, in which 77 patients show candida in the trachea and the bronchial secretion, but no single case of histopathological evidence of candida pneumonia. So candida colonization is mostly colonization in bronchial secretion, urine, stool, wound swab, and gastric juices. And most of the cases, most infections are in pleural effusion, ascites, peritoneal fluid, CSF, histology, and blood cultures. Indication of antifungal therapy is invasive candidiasis, detection in the sterile sample, blood, pleura, peritoneum, CSF, and the fluid. Classical indication in the internal intensive medicine is candida positive blood cultures. However, if the patient is in the circulatory shock, despite of the broad spectrum antibiotics, no other explanation of the fever, high inflammatory markers like high CRP levels, low serum procalcitonin. So, and there is a risk factor of candidemia, then we have to start empirical antifungal therapy. In 2019, ESICM and ESCMID guidelines for the management of invasive candidiasis in critical ill patient, they recommended empirical antifungal therapy with echinocandin in non-neutropenic patient with septic shock and multi-organ dysfunction. Empirical study. It is an empirical micafungin treatment and survival without invasive fungal infection in the adult with ICU-acquired sepsis, candida colonization, and multi-organ dysfunction. Multicentric study. 260 critically ill non-neutropenic patient with sepsis and MODS included, who are on broad spectrum antibiotics, and evidence of colonization at several sites with candida. Empirical therapy with echinocandin and placebo therapy is given. Results are empirical therapy, no reduction in mortality after the 28 days. Diagnosis of the aspergillosis. Aspergillosis criteria are EORTC. EORTC is European Organization of Research of Cancer and Mycosis Study Group. And second is Blue Pass criteria, which include the COPD patient which is affected by aspergillosis. And third is Aspergillus ICU criteria, in which 3 points are there: host factor, clinical factor, and mycological findings. In host factor, EORTCG or MSG criteria includes recent history of neutropenia, less than 500 neutrophils per liter for more than 10 days, that is temporarily related to onset of the fungal disease. Second is recipient of allogenic stem cell transplantation. Then third is prolonged use of steroids at minimum dose of 0.3 mg per kg per day of prednisolone, equivalent for more than 3 weeks. And fourth is treatment with other recognized T-cell immunosuppressant like cyclosporin, TNF-alpha blockers, and etc. during the previous 90 days. And fifth is inherited severe immunodeficiencies. In clinical data, patient must have subjected at least one CT scan and must exhibit one of the following 3 signs, like dense, well-circumscribed lesion with or without halo signs, and air crescent sign, or cavity. In mycological findings, positive culture and microscopic result for aspergillus from the lower respiratory tract, and positive serum ball galactomannan test. In Blue Pass criteria, host criteria include the patient with pulmonary function levels of stage 3 and 4 according to GOLD guidelines. And second is patient with steroids with no strict requirement regarding the usage and dosage of the duration. Clinical data include patient with recent exacerbation of dyspnea despite of administration of antibiotics and progressive deterioration of chest finding. In mycological finding, positive culture or microscopy findings for Aspergillus. In lower respiratory tract infection, positive serum antibody test for Aspergillus fumigatus and two consecutive positive serum galactomannan test. In ASP ICU criteria, neutropenia, underlying hematological oncological malignancies, steroid treatment, congenital or acquired immunodeficiency in host criteria. Clinical data include one of the following in fever refractory to at least 3 days for appropriate antibiotic therapy, recurrent fever after the period of deference of at least 48 hours, while still on the antibiotics and without other cause, pleuritic chest pain, pleuritic rub, dyspnea, hemoptysis, worsening of respiratory efficiencies, and patient with abnormal chest x-rays. And mycological include the positive culture for Aspergillus. So this is summarized like if positive mycology or histopathology of sterile sample obtained in the sterile manner, then it is proven invasive aspergillosis. Second is EORTC or MSG criteria. If host criteria, clinical criteria, and mycological criteria, all three are present, this is probable invasive aspergillosis. If only host criteria and clinical criteria is present, then it is possible invasive aspergillosis. As per ASP-ICU criteria, if Aspergillus positive in respiratory tract, clinical criteria is present, abnormal medical imaging is present, and host criteria 4 is neutropenia, cancer, steroid immunodeficiency, or semi-quantitative positive cultures. All these 4 are present. This is probable invasive aspergillosis. If it is less than 4 criteria, it is colonization. In BM, as per ICU criteria, if EORTC host criteria, abnormal medical imaging, and first mycological criteria, all three are present, then it is all 3A finding. This is probable invasive aspergillosis. If less than 3A is possible invasive aspergillosis. 5B is B in B criteria, ASP ICU host criteria, clinical criteria, and this fungal criteria. If less than 5B, it is possible invasive aspergillosis. Diagnostic for aspergillosis is imaging, chest X-ray or chest CT findings, especially HRCT, high resolution CT scan. Cranial CT, including paranasal sinuses, should be generally performed to rule out cerebral aspergillosis. CT chest rule out invasive aspergillosis with a high degree of probability. Signs in CT chest is halo sign, which is ground glass density increased around the pulmonary focus. Air crescent signs and cavern is differential diagnosis in the TB also. Calcified cavern is classically found in TB, not in aspergillosis. Tracheal and bronchial secretions, as per ASP-ICU criteria, a positive detection of aspergillus must never be ignored. Uh, Quite is contrast to Candida. Candida colonization, Candida is treated like colonization, but presence of aspergillus in bronchial or tracheal secretion is always aspergillosis only, and we have to treat. An infection in the sense of invasive aspergillosis is present in neutropenia even in the 70% cases. In case of positive detection, antifungal therapy should always be immediately. The therapy should be continued if HRCT is positive, galactomannan test is positive, and bronchoscopy suggestive of gray membrane which cannot be washed away with the samples. Then galactomannan test is Aspergillus antigen test. It is a polysaccharide galactomannan in the cell wall component released by Aspergillus. It is antigen detection. Material used is the serum, BAL sample, and CSF. In serum, cutoff is 0.5 nanogram per ml. Sensitivity is 42%. And BAL sample sensitivity is 88%. Then causes of false positive beta D glucose results are false positive results seen in the human blood product, albumin, immunoglobulin, coagulation factor, plasma protein factors, hemodialysis, surgical gauze or other material, antibiotic like piptase, and ampicillin clavular, systemic bacterial infection, excess manipulation of the sample, severe myositis. Fungus that yield positive beta D glucon results are the yeast, Candida, Trichosporon, Saccharomyces cerevisiae, molds, Aspergillus fusarium, dimorphic fungus like Coccidiomycosis, Histoplasma, and others is Pneumocystis zearwachi. Then second is PCR. Detection in Aspergillus DNA from the blood. It is included in EORTC, European Organization of Research and Treatment of Cancer, since 2020 in the neutropenic patient with underlying hematological disease. PCR is important. Assessment is good in the neutropenic patient with a high negative predictive value. If two negative PCR, then in 92.4% no invasive aspergillosis as per studies. Results are very poor in non-neutropenic patients, sensitivity only 11%. And if a patient is already on azole prophylaxis also, PCR detection is difficult. Then blood culture is almost always negative in the mold infection, but if it is positive, it is 100% mortality. Then techniques, culture method sensitivity is 50, but specificity is 100%. Gold standard and delay in the diagnosis and low sensitivity is disadvantage. PCR is 90% sensitivity, 100% specificity. It is highly accurate, but low commercial available. Beta D glucose sensitivity 70 to 80%, specificity 87 to 96%. It is pan-fungal marker, high sensitivity and specificity. Many false positive found in the beta D glucose levels. Galactomanins are 80 to 90% sensitivity and specificity. Shows increased accuracy for the aspergillus detection in the hemato-oncological diseases. Only for aspergillus it is there, but many false positive results are also there. Menin and anti-menin combinations are 60 to 89% sensitivity. Specificity is 80 to 84%. Good specificity and sensitivity with combined use. Results very limited experience. So when we start invasive fungal management is prophylactic, primitive, empirical, and therapy. Prophylactic when we start is asymptomatic high risk patient, we will start prophylactic antifungal therapy. Preventive therapy when asymptomatic and colonization, any novel diagnostic is present, then empirical is high risk patient which on antibiotics and fever we will start an empirical therapy. And therapy is evidence of infection and clinical diseases are present, then therapeutic. Invasive fungal management is there. Pros and cons are: pros for these therapies are high mortality, difficult to diagnose, undetected infection, reduce systemic mycosis, improve mortality with the prophylaxis. Cons of treatment is toxicity of the antifungal, expensive, diagnosis is not certain, too much treatment without infection and too little treatment with infection. Therapy is first eliminate the risk factor like antibiotics, steroid, discontinue hydrocortisone if possible. For candidemia, always plastic changes all excess CVC lines, etc. And candidemia or search for organ manifestation like T for serious on to rule out endocarditis, fundoscopy for ophthalmological rule out, and to rule out chorioretinitis. Then regular blood culture controls and duration of therapy up to 14 days after the first negative blood culture. Antifungal overview. Azoles are inhibitors of ergosterol synthesis, and first generation include fluconazole and itraconazole. Second generation include voriconazole, fosaconazole, and isavuconazole. And polyenes. Polyenes is pore formation or perforation of the fungal cell membrane, which include amphotericin B and nystatin. Echinocandins inhibit the glucose synthesis, osmotic lysis, and single dose is sufficient. All of the three kinocandins are equally effective, and it is fungicidal. And first generation include the caspofungin, second generation is anidulafungin, and third generation is risafungin. Fluconazole is first generation azoles. Spectrum is Candida albicans. Candida albicans is resistant in 10%. It is fungistatic, and gap in effectiveness. It is not working again. Candida cruzi and tropicalis. Dose is day one 800 mg loading dose followed by 400 mg per day, and Increase resistance to Candida glabrata. Frequently, significantly increase MIC for the Candida glabrata is seen. Prophylactically also recommended for the gastrointestinal perforation or anastomotic leak. And enhancement effect are seen with the coumarin, sulfonylureas, theophylline, phenytoin. Dose adjustment for the renal insufficiency is when creatinine clearance is less than 50 ml per minute, we have to reduce dose to half. And side effects are the leukopenia, thrombocytopenia, diarrhea, hepatotoxicity, prolonged QT interval. In IDSA guidelines 2013, no longer recommended as an initial therapy for critically ill patient with candidemia. Echinocandin should be used. Voriconazole is second generation azole. Indication is drug of the choice for aspergillosis and severe candidiasis, candida paraphylosis, severe infection with halohypomycositis like a fusarium, in which it is drug of choice, and prophylaxis in both primary secondary prophylaxis of invasive mycosis after allogenic stem cell transmission. It is approved since 2014. Gap in effectiveness is it is not working against mucorales, and dose is IV is first day 6 mg per kg BD loading dose followed by 4 mg per kg BD. Per oral first day is 400 mg BD loading dose, then 200 mg BD. There is a no dose reduction in the renal with oral forms of the voriconazole, but hepatic insufficiency we have to reduce the dose. In parenteral form of the voriconazole, it contains the solubilizer like the cyclodestrine vehicle. Since voriconazole is extremely lipophilic, this may accumulate in the renal insufficiency. Therefore, at least according to the official drug information, we will prefer only oral therapy if the GFR is less than 50. Higher doses is needed for the cerebral aspergillosis and nephrotoxicity of the second line therapy with limpo. Side effects are the fever, chills, headache, nausea, vomiting, diarrhea, edema, skin rashes, peritonitis, visual disturbances in the 30% of the patient, which is reversible. Inhibitors of the enzyme is the cytochrome P450, no simultaneous administration with the rifampicin, carbamazepine, phenobarbital, quinidone, and the glucocorticoids, especially dexamethasone, are the inducers of the cytochrome P450 and reduce the concentration of azole antimycosis. So this is much more the case with the voriconazole than the isavuconazole. Also, we'll be careful with the simultaneous admission of the NOACs with the voriconazole. Therapeutic drug monitoring is obligatory, and often fluctuation level with the metabolism depend upon the cytochrome genotype. The mortality of the invasive aspergillosis is 70%. To carry out a voriconazole therapy today without therapeutic drug monitoring is therefore a malpractice. And target trough level is 1.5 to 5, and voriconazole therapeutic drug monitoring is compulsory. Then fosaconazole is second generation. It is available in the syrup form, pill form, and the parenteral solution. It is broadest spectrum for effective for all antifungal. Dose per oral is 200 TID daily, preferably taken with a fatty meal. If we are taking pill form, then one pill is 100 mg, day one 300 mg BD, then 300 mg OD dose is there. IV form day one is 300 mg BD, then 300 mg OD. Indications are invasive aspergillus, mucorales, and coccidioids. Drug adjustment in renal and hepatic insufficiency should be there. It is used in hematology mainly for the prophylaxis of the invasive mycosis in the hematological high risk patient. And therefore, in hepatic efficiency, no dose adjustment is there. And in renal insufficiencies, same, it is like voriconazole, it is releasing cyclodextron in the IV form, so that in a low GFR patient, we have to reduce parenteral dose. Side effects are the nausea, vomiting, diarrhea, hepatotoxic, and no interaction with the proton pump inhibitor H2 blockers, and interaction with cyclosporin and other immunosuppressant. Isavuconazole is second generation. It is a triazole approved for the invasive aspergillosis as per secure study, also for the mucormycosis in the vital study. Dose is one pill is 100 mg, same dose with high oral bioavailability, and IV for 2 days, 200 mg TID followed by 200 mg OD dose. Less hepatotoxic compared to voriconazole, in contrast to voriconazole and fosaconazole, hydrophilic and not lipophilic, which could accumulate in the renal efficiency if required. No dose reduction in renal and the hepatic insufficiency because cyclodextron is not available in the IV form. Side effect increase decrease QT interval. Therapeutic drug monitoring is required. Trough level is 2 to 5 microgram per ml, but routine trough level monitoring is not recommended in this patient. Only trough level monitoring is recommended in severe case of aspergillosis and the mucormycosis. Then amphotericin B. It is a poly in antifungals. Its spectrum include the Candida, Cryptococcus, Aspergillus. Doses are initially 0.25 mg per kg over 6 hours, then increase within 2 days to 1 mg per kg. No combination with azoles because antagonism. Side effects are the leukopenia, thrombocytopenia, transaminitis, allergic reaction, hypokalemia, renal diabetes insipidus, nephrotoxicity. Classical side effect is acute kidney failure due to amphotericin B, and liposomal amphotericin B also shows the acute kidney failure in the 10% of the cases, but no dose reduction necessary for renal efficiency in the CRRT. Echinocandins are the first is caspofungin. It is first generation broad spectrum antibiotics. Spectrum include the Candida aspergillus, and loading dose is 70 mg followed by 50 mg. Cytochrome P450 inducers, especially rifampicin, rifabutin, all these things, it is inducers, and no dose reduction necessary in the renal efficiency, but in hepatic, if insufficiency, dose reduction to 35 mg. Side effects are rare, but fever, phlebitis, hemolysis is seen. Anidulafungin is second generation echinocandin approved in the invasive candidiasis, candidemia, and dose is first day 200 mg and then 100 mg per day. No dose adjustment in renal and the hepatic insufficiency. Side effect coagulopathy, seizures, headache, hypokalemia, pruritus, transaminitis, atrial fibrillation, diarrhea, hypotension. Then micafungin. It is second generation echinocandin, broad spectrum echinocandins approved for prophylaxis after the stem cell transplantation, neutropenia, or systemic candidiasis in all esophagitis. Only echinocandin which is approved for the prophylaxis since 2019. Dose is prophylactic dose is 50 mg daily. Therapeutic in systemic candidiasis 100 mg OD daily, and in esophagitis 150 mg daily. No dose reduction in hepatic and renal insufficiency. Restriction of approval according to official drug information and EMA due to warning regarding to the liver damage in case of other antifungals which are not effective. Risafungin is third generation echinocandin. It administered only once a week if necessary. Dose is 400 mg, then 200 mg infusion. Duration 1 hour, and half-life is very long. In STRIVE study, non-inferior to caspofungin in the candidemia with regard to combined endpoint. Side effects are especially in diarrhea, hypokalemia, fever, no dose reduction in renal and the hepatic. It is approved by FDA in the USA since 2023. In European guidelines, for the diagnosis management of Candida disease 2012 non-neutropenic adult patients, it is recommended echinocandins are the highest grade for the candidemia or the invasive candidiasis, while only a grade C recommendation for the fluconazole. No more therapy for the candidemia, mortality 50% critically ill patient with fluconazole. So drug of the choice is echinocandin, and duration of therapy for invasive aspergillosis at least 4 weeks. Mucormycosis is third most common after Candida and the Aspergillus, and disease is mucormycosis. Species is Rhizopus, and types are the rhino orbitocerebral, which is most common type, involve causing swelling, redness, and pain in the face, orbit, possibly blindness also. Second is pulmonary type, gastrointestinal, then cutaneous, then disseminated form, which show the highest which is fatal and high mortality. It is common in the immunosuppressed patient. Risk factors are the diabetes mellitus and hemato-oncological disease, neutropenia, immunosuppressions, hematopoietic stem cell transplantation, and patients on desferrixamine therapy. It is typically invasive growth among all other and show angioinvasion with thrombosis infarction. Mortality is 50%. Diagnosis by the histopathological cultures and serology and CT scan. In a CT scan, pulmonary type shows the multiple bilateral round foci in the lungs, pleural effusion, reverse halo signs, and if mucormycosis is proven, CT skull is also important. Therapy. Therapy is generally surgical therapy with antifungal therapy, especially in rhino-orbital cerebral form. Recurrent debridements are required along with antifungals. Drug of the first choice is liposomal amphotericin B. High doses 10 mg per kg is required in this one. And drug of second choice is azole, isavuconazole, posaconazole, and voriconazole is ineffective in this condition. Duration of therapy is until the permanent end of the immunosuppression or complete response of the therapy shown in the CT. Cryptococcus is also belongs to the sprouted fungus, especially Cryptococcus neoformans. It is mostly seen by inhalation of the contaminated with the bird droppings, pigeon droppings, almost exclusive in the patient with the severe immunosuppressions like HIV patients, lymphoma, sarcoidosis, chronic steroid therapy, or organ transplantation. Drug of choice is lymphosomal amphotericin B. In case of severe or cerebral infection, addition of the 5-fluorocytosine is also recommended. Dose is 100 to 150 mg per kg, divided in 4 single doses daily. Side effects are mainly allergic reaction, nausea, vomiting, diarrhea, and liver dysfunction. Dose reduction in renal insufficiency is required. Therapeutic drug monitoring is recommended. Trough level is 25 to 50 picogram per ml. And emerging new fungus are the emergomyces, histoplasma, and the fusarium. Emergomyces is dimorphic fungus. It is spread by the soil in the molds where conidia is released and aerosolized and inhaled by the humans, which shows the pulmonary diseases. Yeast like disseminated homogeneous infection is also seen. Most common form is in India. Most common form in India is Emergomyces pasturena, which causes emergomyces. It is common in HIV patient, neutropenia, immunosuppression, diagnosed by histopathology, fungal culture, bone marrow aspiration, biopsy, BAL samples, and the treatment by a liposomal amphotericin B for 1 to 2 weeks, followed by tablet itraconazole, lifelong tablet itraconazole therapy in case of emergomyces. Fusarium is first found in the Kolkata, 1958. Transmission to air droplet, skin infection. It affects eyes, blood, kidneys, lung lesions, escars, and diagnosed by beta-D glucose levels, galactomannan, PCR, Maldifort. Highly resistant to antifungals, liposomal amphotericin B is treatment and surgical debridement is needed. Mortality is high. Histoplasma is common in HIV patient. End-stage liver disease, diabetes, neutropenic, mode of transmission, air droplet, animal to human, manifestation, cough, fever, malaise, dyspnea, diagnosed by the cultures, histopathology, bone marrow aspiration, treatment with liposomal amphotericin B followed by itraconazole. Empirical anti-candida therapy is cost effective or not. To target patient in the ICU more than 3 days and unresponsive to antibacterial therapy for more than 3 days. Strategies compare between fluconazole, caspofungin, amphotericin B, and lymphosomal amphotericin B. So caspofungin is cost effective, but fluconazole is more. Caspofungin is most effective, but fluconazole is cost effective. Consideration of empirical antifungal therapy in the high-risk patient with hematological malignancies, transplantation, immunosuppressions, and patient not compliant to drugs, prolonged or recent exposure to azoles, pathogen in vitro susceptibility pattern for class of agent, and site of infection like ocular, CNS, and urinary with cystitis. Azoles, fluconazole is most common agent in use in the candida infection. Triazoles have a role in non-nucleoside analog therapy and the immunosuppressive therapy. Amphotericin B is active but is not superior to other therapy. Therefore, it does not justify the risk for the toxicity. Echinocandin shown to be as more effective than amphotericin B or liposomal amphotericin B and is not associated with significant resistance. Limited CNS and genitourinary penetration is seen. Removal of all foreign bodies correlate with better outcomes, and albicans biofilm formed on an implanted medical device, CVC, urinary catheter, ETT. So we should remove the CVC line, etc., so that biofilm problems is reduced and resistance is decreased. And in case we are not able to remove all these things, then echinocandin is the better choice. This is algorithm for empirical therapy. If invasive candidiasis is there, hemodynamically stable, then if azole resistance is there, probability of azole resistance is present, then we have to use echinocandin and amphotericin. If azole resistance is not seen, then fluconazole is drug of choice. If patient is not stable, then echinocandin and amphotericin B is treatment. De-escalation of therapy is demonstrated the safety of approach at the 5th day in the proven invasive candidiasis. In candidemia, de-escalation from echinocandin to fluconazole for azole susceptibility isolates when the repeat blood cultures are negative and the patient is clinically stable and is recommended within 5 to 7 days in the IDSA and 10 days in the ESCMID guidelines. Duration of therapy for candidemia should be treatment for at least 14 days after the first negative blood culture. It is also suggested that invasive candidiasis without positive blood culture should be treated for 10 to 14 days. Adequate source control is important for invasive candidiasis. In case where intravascular catheter or other foreign material cannot be removed, echinocandin should not be de-escalated to azoles. Combination therapy, the use of combination therapy for antifungal for invasive pulmonary aspergillosis is still debated. And theoretically, it can achieve potential synergistic effect, broad spectrum antifungal spectrum, and potential reduction of acquired resistance. But in vitro and human studies are very less. The use of combination therapy may be considered in case of resistance in central nervous system aspergillosis due to azole resistance, a broad initial coverage pending pathogen identification for salvage therapy in refractory disease and until adequate plasma concentration for voriconazole can be documented. For combination antifungal therapy for invasive aspergillosis, studies are there. It is a prospective study in which 454 patients are there, in which one group voriconazole is given and second group voriconazole plus antifungal is given. So results after 6 weeks, there is a no reduction in mortality in combined group. Anti-salvage treatment is in general, there is a 2-drug related reason for treatment failure, either refractory mucormycosis or toxicity of the first line regime, means intolerance to the drug. For amphotericin B formulation, particularly renal toxicity can be a limiting factor. For azole, hepatotoxicity is highest. Toxicity can be caused by previous antifungals or expected due to pre-existing organ damage. Only 2 drug classes have proven efficacy in the mucormycosis. The salvage treatment means mostly switching to the other class. Isavuconazole is strongly supported as a salvage therapy. Fosaconazole delayed release tablet or infusions are strongly supported for the salvage treatment, and when available should be preferred over fosaconazole oral suspension, which in turn marginally supported for the salvage therapy. In case of the primary treatment failure with isavuconazole or fosaconazole, recommendation for all 3 lipid-based amphotericin B formulation. So in summary, if suspected invasive candidiasis is there, we obtain blood culture and 2 consecutive 2 beta D glucose levels. Presence of multiple risk factors. If candida score is more than 3, if it is present, we have to start echinocandin. If it is not present, no antifungal therapy. We will wait for the blood culture to beta D glucose level 2 to 5 days. If it is positive, continue or initiate echinocandins. Consider fluconazole in clinically stable patients with low risk resistant groups only. If it is negative, consider discontinue antifungal therapy. If it is positive, then at least we have to treat for the 14 days. For empirical treatment for a suspected candidemia is persistent despite antibiotics, risk factors are present, we have to start empirical treatment. It is strong recommendation. Empirical treatment or curative treatment is removal of catheters, everything. Clinically unstable or recent azole exposure, high rate of the azole resistance. If all these are not present, then fluconazole we can start. If anything is present, we have to start echinocandin and liposomal amphotericin B. It is strong recommendation. For invasive aspergillosis, primary treatment is voriconazole, followed by oral administration of voriconazole till stabilization of clinical and the radiological finding, or administration of liposomal amphotericin B, followed by administration of oral voriconazole or itraconazole. Salvage therapy is IV administration of caspofungin or fosaconazole. So, in summary, in patient with septic shock, risk factor for candidemia should be evaluated. If candida infection is suspected, treatment will need to initiated empirically without delay on the basis of individual patient factors before a definitive diagnosis is made. Choice of the agent will rely on local resistant pattern, microbiological data, previous azole exposure, recent GI surgeries, neutropenia, hemodynamic stability, and other host factor. Azoles are effective unless high rate of the resistance or neutropenia, in which case echinocandins are used, and candidemia is associated with high morbidity mortality in the ICU. So early appropriate therapy should be started. Combination of clinical lab findings used to make the diagnosis. Prophylactic and primitive therapy may be indicated in the high-risk population at a risk of candida infection. And when candidemia is documented, and ID of the infecting candida species is essential for the institute for the appropriate therapy because of the variable susceptibility of the candida species to different antifungal agents. So we do not forget to address the biofilms. Thank you, sir.
Thank you, Smita. I think it's a vast topic which has been covered extensively in a very lucid manner. I think fungal infections are rising and the resistance patterns are also increasing across the world, and not only in the world, in India. While we are all focusing on antimicrobial stewardship for antibiotics, we should not forget antifungals, and a rational approach is needed because the pipeline for antifungals is also as thin or as bare as it is for the antibiotics. So a lot of discipline is needed. Thank you all for joining us today. If there are any queries and comments on this topic, please post them on the group from where you got the link from, and we will answer them at the earliest possible opportunity. Join us again next week for another session on the Higgs platform. Subscribe to the YouTube channel, and please do register for the 10th annual Higgs conference on June 19th to 22nd in Hyderabad. See you all very soon. Bye-bye.
Thank you, sir.